A very good afternoon to one and all. So at the outset, I want to thank the organizers for giving me this opportunity. And as I just went through the schedule, most of the topics are related to genetics, and my talk may stand a bit odd out as I'm going to discuss on a different technique, which is flow cytometry, and its utility in the diagnosis of inborn errors of immunity, formerly called primary immunodeficiency disorders. So I may use these terms a bit interchangeably in subsequent slides. So without wasting much time, let's go into the topic. So we all know the basic function of the immune system is to fight against the pathogens which invade our body. But beyond that, the immune system also has some other functions like tumor surveillance, where the immune system identifies a cancer cell or a pre-cancerous cells and eliminate them before they cause any harm. So that is the reason why we have increased predisposition to malignancy in patients with immunodeficiency. So the immune system is very important to keep a check on malignant cells. The other important function of immune cells is to maintain a tolerance where they function in a regulated fashion. When this fails, this results in immune dysregulation and autoimmunity, where our own immune cells can affect the self antigens or our own cells and tissues, causing autoimmune disorders. So, the immune system has a multifaceted function and it is not just protecting against infections. Now, if we just go through the inborn errors of immunity, they are a group of inherited disorders that can affect cells of the innate or adaptive immune system. So it can affect both the natural immunity as well as the acquired immunity. These disorders are uncommon, but it is not rare. Most of these disorders earlier were underdiagnosed because we didn't have a good diagnostic modality to pick up these cases. But now, with the advent of techniques like flow cytometry and next generation sequencing, many such disorders are being picked up and we are diagnosing those cases. So, my point is it is uncommon, but it is not rare. So, you need to have an high degree of suspicion when you are finding children or patients with repeated or repetitive infections requiring hospitalization or IV antibiotics to clear their infections. And the overall prevalence is about 1 is to 1200. It can present in any age from the newborn period to adulthood. So basically, it depends upon what type of immunodeficiency you have. For example, if you have a combined immunodeficiency or deficiency of cell-mediated immunity corresponded by the T cells, the disorder presents more in an earlier age, like less than 6 months. Whereas in contrast, if you have a defect in the immunity, which is basically given by the B cells, the disorder presents later or after 6 months of age. The reason being like till 6 months, the maternal immunoglobulin will be there in the child, taking care of the child. Once this subsides, the, the B cells of the patient does not produce immunoglobulins and then they later show signs of infections and symptoms. So the timing of presentation of the child is also very important to identify what type of immunodeficiency the child has. So recognizing different clinical manifestations of IE, inborn errors of immunity is also a very, very important step. Now, coming to the categories, these PIDs are basically categorized into multiple types. Basically, like a combined T and B cell immunodeficiency, which predominantly affects the cell-mediated immunity or the T cells. Remember, like if the T cells are defective, then the B cells, though you have the B cells numbers or quantitatively, they are qualitatively defective. That simple reason because the T cells are needed for the activation of B cells to function. So when you don't have T cells, though you have the B cells, they are functionless or they are poor in function. Okay, so these disorders are called combined T and B cell immunodeficiencies, commonly called as SCID when it is presenting in a severe form. The other category is the same combined immunodeficiency with syndromic features. predominantly antibody deficiency, which is an immural deficiency, diseases of immune dysregulation like your HLH, MSMD, and those conditions, congenital defects of phagocyte numbers and functions, for example, congenital neutropenia, CGD, leukocyte adhesion defect, all comes under this category. Then disorders in innate immunity, as I said, these are the disorders with natural immunity or the NK cells, and these comes under this criteria. Autoinflammatory disorders, complement deficiencies, and recently two more entities have been added to this category, which is phenocopies of PID, and one more is bone marrow failure syndromes has been added to inborn errors of immunity in the recent classification. So these are the categories, and these are the incidents of these particular categories. So basically, most common is antibody deficiencies or disorders of humoral immunity. Okay. Now, the Jeffrey Model Foundation has established 10 warning signs to pick up cases of suspected PID. So these include repeated ear infections, sinus infections, or pneumonias in 1 year. And there are two or more months of antibiotics with little effect, or you need IV antibiotics to clear the infections, failure of an infant to gain weight, recurrent and deep-seated abscess or organ abscesses, and oral thrush, that is candidiasis or fungal infections of the skin. So, and a very, very important family history of PID, that is an early sibling death or an sibling with the previously diagnosed inborn errors of immunity, are all very, very typical warning signs that this particular patient may have a primary immunodeficiency disorders. And they have said, like, if you find two or more of these warning signs, then that particular patient has to be evaluated for inborn errors of immunity. With the advent of next generation sequencing, new mutations are picked up in suspected cases by whole exome sequencing, and it is being reported. Hence, the number of PIDs reported is steadily increasing, and soon it may reach 500 in number. Though they are grouped under 10 categories, we almost have 5 different PIDs, due to different genetic defects. So though there are, as I previously said, there are 10 categories, but the 10 categories have 500 different PIDs with different gene defects. So the numbers are increasing day by day, and it's all because of the introduction of next generation sequencing, which is picking up all novel mutations in suspected cases of immunodeficiency. So whenever a sample comes to us for PID workup, what we insist is for a good history and examination findings, and we request the clinician to fill up this form or a questionnaire so that it helps us to narrow out what could be the cause for the primary immunodeficiency disorder, or what is the diagnosis basically. So this includes basically the warning signs which I've already showed you. Apart from that, we also insist on the age at onset, for the simple reason which I said you earlier, because the T cell defects or the cell mediated defects present before 6 months of age, whereas the immural defect and the phagocytic defects present a bit later than 6 months of age. Then is there a tonsils? Is there lymphadenopathy? Was the separation of umbilical cord happened in a timely fashion, or was it delayed? Was there any candidiasis? Was there any pathogenic infections? And what was the pathogen which has caused infection? So all these things was how was the patient reaction to a live attenuated vaccine like BCG? Are there any skin lesions? Are there any syndromic features? Is there any family history of sibling death? And very importantly, immunoglobulin profile. Very important is immunoglobulin profile, because if the immunoglobulin profile is normal, then it means like the T cells and B cells are functioning quite well. And immunoglobulin profile has to be has to be considered only after 6 months of age, because until 6 months the maternal immunoglobulins will be in circulation and you cannot take that into consideration. And similarly, the immunoglobulin what you are seeing, there should not be any history of IVIG administration. So that is also very, very important, and we have added that as also as an point during our request. If you see our immune system, it is very diverse. For example, you take the lymphocytes, you have the B lymphocytes, T lymphocytes, NK cells. If you take T cells, there are CD4 positive cells, CD8 positive cells. And if you take CD4 positive cells, you have the naive CD4 positive, central memory CD4 positive, effector memory CD4 positive, effector CD4 positive T cells. You have T regulatory cells. So it is very diverse, and you need to have an efficient tool to study and characterize these diverse immune cells. One such technique is flow cytometry, which can help in discriminating the cells by the antigenic properties or the proteins which are present on the cell surface, which is always said by the CD molecules with a number. So these, whenever they call a CD molecule, say like for example CD4, it basically means a cluster differentiation marker or a protein which is present on the cell surface. Okay, and flow cytometry is very good in discriminating the cells by using these antigens or proteins present on the cell surface or within the cell surface. So as the name indicates, flow cytometry is nothing but you're going to study or measure the cell in a flowing stream. Flow is flow, cyto is cell, metry is measure or study. Okay, so you're studying the cell as a cell flows through a stream. So that is called flow cytometry, and this is how it happens. You have a mixture of cells, and as they flow through one at a time, they are getting interrogated by the laser, and they are studied for the physical properties as well as the fluorescent properties. I'll since this topic is a very broader one, I cannot go very deep into flow cytometry basics to teach you the technique, but I can just give you a small idea of the principle how this is working. So here we have a cell, a target cell of interest, and it has an antigen which is very characteristic to the cell. Now what we do is that we use an antibody which is tagged to a fluorochrome. So once we add this, since this antibody is complementary to this antigen of interest, it goes and binds to it. Now this particular cell is passed through a laser beam, and this laser beam hits the fluorochrome tagged to the antibody if it is attached to the target antigen. So that laser beam hits the fluorochrome, and the fluorochrome emits light of a different wavelength called the emission light, which is picked up by the detector, which gives you a signal. Okay, in case if this particular antigen is not present in that cell, this antibody will not bind and you will not get the signal. And that is how flow cytometry picks up the cells or the target antigens. Okay, so for example, if this is a CD4 positive T helper cells, this is the CD4 antigen. We use an anti-CD4 molecule, and once it goes through the flow cytometer, if it gives signal, that means like there are CD4 positive cells. If there is no signal, then those cells are not having CD4 molecule in it. So this is the basic principle of flow cytometry, what is happening. And the beauty is that you can study as many antigens or proteins on the cells at a given point of time in one single cell by using different fluorochromes. So that is the beauty of flow cytometry. Now, since I'm going to discuss or show you a lot of dot plots or flow cytometry data, I'll just give you a basic of how this has to be interpreted. Now, you have a combination of cells, and what I'm doing is I am using two different antibodies against two different antigens. For example, an antibody to antigen A. Just assume that this could be some marker CD4, and an antibody against antigen B, which can be, for example, CD8, and both are tagged to two different fluorochromes, APC and FITC. Now, once I add this, I get a data like this. Okay. Now, the top, the left, bottom left corner, this particular quadrant. Okay. Now it has been labeled. The x-axis has been labeled with FITC, which is your CD8, and for example, and the y-axis has been labeled with APC, which is CD4, for example. Okay. Now, cells falling in this quadrant, that is the lower right quadrant, okay, is only positive for the x-axis marker, okay, which is CD8. So these are CD8 positive cells, okay. Whereas cells falling in this left top corner, okay, is positive only for CD4, okay, which is APC. Cells falling in this quadrant, that is the lower left quadrant, okay, is negative for both CD4 and CD8, okay. See, and cells falling in this top right quadrant is positive for both CD4 and CD8. So that is how you need to interpret a dot plot or a flow cytometry data plot. Okay, so because since I'm going to show you some of these plots in the subsequent slides, I just want to give you an overview of this. Okay, so it's basically like an x-axis marker and a y-axis marker. Population falling here is positive for both x and y-axis marker. Population falling here is negative for both x and y-axis markers. Population falling here is positive for x and negative for y. And population or cells falling here is positive for y-axis marker and negative for x-axis marker. Now, the diagnosis of inborn errors of immunity by flow cytometry. Okay, so as I discussed, the flow cytometry is a technology that rapidly analyzes. This is very important because flow cytometry technique, the beauty of flow cytometry is it can rapidly analyze the cells. It can analyze say like 10,000 to 1 lakh cells in 1 second. It is so fast, and you get this. You give the sample in the morning, you get the report in the evening. So it is so fast, and that is the beauty of flow cytometry. And it analyzes single cells. Okay, so for a sample to be analyzed in flow cytometry, the basic requirement is the cell has to be in a single suspension or in a single phase. So because only one cell will be analyzed at a given point of time. Okay, it is not like tissue biopsy or IHC where you see all the cells together. Here, only one cell will be analyzed at a given point of time, and they are analyzed as they are in a flowing stream, as I said you, when they cross the laser beam. Okay, so it is a very efficient tool for studying the cellular antigens or proteins present in the cells. Okay, now how does flow cytometry help in the diagnosis of inborn errors of immunity or PIDs is basically by three methods. One, will if there is a decrease or absence of one or more immune cell subsets. For example, you are studying the lymphocytes. If there is complete absence of T cells, or if the T cells are reduced, we can diagnose the condition as combined immunodeficiency. And for another example is you are studying the lymphocyte and there are complete absence of B lymphocytes. Then the diagnosis is A gamma globulinemia. So diagnosing PIDs based on decreased or absence of one or more immune cell subset. That is one way of diagnosing PIDs by flow cytometry. The other method is by studying the proteins. For example, if there is absence or decreased expression of proteins, we can diagnose some PIDs by flow cytometry. One example is BTK in X-linked A gamma globulinemia and Viscott-Aldrich protein, a VASP protein in Viscott-Aldrich syndrome. So these are some of the examples, and similarly CD18 and CD11 complex in case of leukocyte adhesion defect. So we just target these proteins. If the proteins are present, it is normal. If the proteins are reduced or absent, it is consistent with the disease. So that is one other way of diagnosing PIDs by flow cytometry. And the last way is to study the function of the cell. So it is more of a functional assays. So if the cell shows normal function, then it is normal. If the cell shows loss of function, which is assessed by flow cytometry, then it is consistent with disease. And an example for this particular category is the diagnosis of chronic granulomatous disease by a test called DHR by flow cytometry. So I'll just elaborate this in the subsequent slides. So we'll just see these particular utility of flow cytometry in the diagnosis of PID with respect to case scenario so that it makes us more interesting. So this particular kid, 2 months old male infant, had a BCG vaccine and he had an exaggerated response to the BCG vaccine. He had swelling, pain, fever, and you can see the swelling in the left axilla. Okay, so you know BCG is a live attenuated vaccine, and you find there is a swelling in the axillary region. The child was feeding well, but on a routine CBC, when the child was taken to the OPD, showed lymphopenia. Now, this particular reaction to a vaccine is something very abnormal. So that should raise an alarm bell against the diagnosis. So that should raise an alarm bell towards the diagnosis of an immunodeficiency. And you see the age of presentation, it's very young, 2 months of age. So basically, this case could be a combined immunodeficiency or a T cell defect. Okay, and CBC is also supporting by a reduced absolute lymphocyte count, that is lymphopenia. So what we did, we studied the lymphocyte subsets in this case. Now, studying the lymphocyte subset, we have two panels. One is a basic lymphocyte subset where we study the T lymphocytes, B lymphocytes, NK cells. The T cells are further categorized as CD4 positive T helper cells, CD8 positive cytotoxic T cells, and double negative T cells. Okay, so this is a basic lymphocyte subset analysis panel. This can help you to diagnose very classic cases of severe combined immunodeficiency or X-linked agammaglobulinemia, but it cannot diagnose some other conditions. So we sometimes use an extended lymphocyte subset analysis where apart from the T, NK, B lymphocyte, CD4, CD8 and double negative, we subtype the CD4 cells into naive memory. The memory in turn is classified into central memory, effector memory and terminally differentiated T cells. We split the double negative T cells as T cell gamma delta cells and T cell alpha beta cells. And again, the B lymphocytes are subdivided into naive B cells, class switched B cells, transitional B cells, and plasma cells. So why should we do this is basically this can unfold or diagnose the other PIDs which will not be covered with the basic panel. Okay. And how do we do this is basically by the phenotype. You should know the phenotype of each of these cells to study them. Okay. So this is the phenotype and these are the cells. For example, if you want to study the naive CD8 positive T cells, it should be CD3 positive, it should be CD8 positive and CD4 negative, and it should be positive for CD27 and CD45RA, which is a naive cell marker. So basically, to study these cells, you should know the phenotype. To study the plasma cells, you should know that it should be CD38 bright. Okay, so if you don't know the phenotype, then you cannot study these cells. So this is the phenotype, and these are the corresponding cells. And with this phenotype, we study these cells in flow cytometry. Coming back to the basic lymphocyte subset analysis. So once we get the lymphocytes are divided into CD19 positive cells, which are the B lymphocytes, CD3 positive lymphocytes, which are T lymphocytes, CD56 and 16 positive lymphocytes, which are NK cells. Okay. Now the CD3 positive cells can be further divided into CD4 T helper cells and CD8 positive cytotoxic T cells, and you have a double negative T cells. So this is a normal lymphocyte subset where you can find a good population of each subset in this plots. Okay. Now, coming to this case one, this was the lymphocyte subset analysis plots. You find that the lymphocytes with CD19 positive, that is B cells, are looking normal, but you find that T cells are completely absent. In contrast to the last slide where I showed you the normal lymphocyte subset, you find the T cells are completely absent. You can find some amount of NK cells there, but the T cells are absent. And similarly, if this is absent, obviously the 4 and 8 subsets are also absent. So there's a complete T cell deficiency in this particular patient, and this is called combined immunodeficiency. It is characterized by the defect in T lymphocytes and B lymphocyte function. I repeat, though the B cells are present, if the T cells are not there, the function of B cells will be deranged because you need T cells for activating the B cells. Okay, that is why though you have B cells, we still call this as combined immunodeficiency. Okay, as T cells are required for the activation of B cells, quantitative and qualitative T cell defect can affect the B cell function. So the first case, the diagnosis is SCID, and this is how we diagnose it by flow cytometry. Okay, now I'll show you some different. This is healthy control. Again, you get the lymphocyte, you see B cells, the T cells, the NK cells beautifully there. And in different SCID types, you can see this is T negative, B positive, NK negative, which means the T cells are not there, B cells are present, NK cells are not there. So the B cells are there, the T cells are not there, the NK cells are not there. So this is T negative, B positive, NK negative. So based on the presence of the population, we give the phenotype name, the SCID, a particular type of SCID. Okay. So this is T negative, B positive, NK positive, where you find no T cells, you find the B cells and the NK cells. And similarly, this is T negative, you don't find T cells also. So it's B negative, but NK cells are there. So it is T negative, B negative, NK positive. That's how we classify SCID based on the phenotype. Okay. This is T negative, B negative, NK negative, where the lymphocytes are completely absent and you don't find either T cells, either B cells, or the NK cells. So nothing is there. Okay. And based on the phenotype of the skid by flow cytometry, it can able to predict the gene mutation. Okay. So if it is T negative, B positive, NK negative, it could be IL2 RG defect, or it could be JAK3 defect. And similarly, for every phenotype, there is a suspected gene mutation. However, it has to be confirmed with gene sequencing or targeted gene panel by next generation sequencing. Okay, so then you can establish the diagnosis. So this is the first case, and let's move on to the second case. So this case is a spotter for any pediatric practicing, like any pediatricians. So you find a child with a lot of excoriations in the skin, desquamation. There is alopecia. There is hepatosplenomegaly, recurrent infections. There is lymphadenopathy, and this is a very classic phenotype of an immunodeficiency state called Omen syndrome. Okay. Now, the phenotype of this particular flow phenotype of this particular child is you find the T cells to be there. Okay. And you can also find a small population or a decreased number of B cells, 19 positive lymphocytes, that is the B cells. So you find the T cells and decreased B cells. But if you study this B cell further, sorry, excuse me, if you study the T cells further, you can find that most of these T cells are in a non-naive state. That is, it is either in the memory state or an activated state. Okay, for make it simple, for especially in children, the naive cells or the naive T cells should be more in number compared to the memory cells. I repeat, in normal situations or normal conditions, normal children, the naive cells should be more in number compared to the memory cells. Okay, but in conditions like leaky skid or atypical skid or also in Omen syndrome, what happens is that these T cells are defective, they are abnormal, they are self-reactive, and they always be in an activated state. So these T cells will be more in show a memory phenotype, and the naive cells will be completely absent or reduced. You see here, the naive cells are reduced compared to the memory cells. Okay, so this is the advantage of using an extended panel, because if you use a basic panel, these cases may be missed, assuming that the CD3 count is normal. But these CD3, though it apparently appears normal, when you do an extended lymphocyte subset analysis, you can find that these are all abnormal due to the fact like there is very reduced naive cells in both CD4 and CD8 compartment. Okay, and to see whether these are all activated or in a non-activated state, because in Omen syndrome, most of the lymphocytes will be in an activated state. In normal patients, in a normal children or a normal patients, most of the T lymphocytes will be in a non-activated state. So we need to use some activation markers like HLA-DR. So when we did for this child, this is a control where you find only a small population of T cells are showing an activation marker or shows an activated state, whereas in this patient you can find that most of the cells are in an activated state exhibiting positivity to HLA-DR. Okay, and only very small number of cells are in a non-activated state. So this is very classic of Omen syndrome. And one more take-home message what I would give with this slide is like whenever you're doing a flow cytometric analysis for immunodeficiency, you always should run a parallel control. You should always run a parallel control so that it stands as a, like to check whether your assay is right. Okay, whether your antibodies are functioning, and it's always better you run a control along with a patient sample. Okay, so this is a classic Omen syndrome where you find a very abnormal T cell expansion, which are autoreactive and which are functionless. Okay, they show a more of memory phenotype instead of naive. The naive cells are reduced and they show positivity to or increased positivity to activation markers. So the second case is a typical Omen syndrome. Now let's go for the third case. So now we have a 3-year male child. So this presentation is slightly later than the last two cases. So the first two cases we had presentation at less than 6 months. Now we have a case presenting at 3 years of male child, and you have repeated respiratory and ear infection. On examination, the pediatrician found there is no tonsil. Okay, this is very classic history for A gamma globinemia. Okay, so blood culture was done. It was positive for Pseudomonas, and this is very important again. Immunoglobulin profile is low. So with these findings, almost we are coming to a conclusion that we have a suspected case of humoral deficiency or a B cell defect. So we just run with the lymphocyte subset analysis where we gated the lymphocytes and we searched for the T cells and B cells. The T cells were quite normal, but if you find the B cells, they are completely absent, almost absent. Okay, so this is a classic case of A gamma globinemia. Since it's a male child, it's likely to be X-linked A gamma globinemia. Okay, so this is a diagnosis of X-linked A gamma globinemia. Now, when you are giving a diagnosis like this, always ask for history. That is why I stressed whenever you are doing flow cytometry for the diagnosis of PIDs, get a good history. Sometimes what happens is that there may be a history of rituximab, which is an anti-CD20 therapy. So that particular drug will completely knock out the B cells and it will be sent for you for lymphocyte subset analysis. Okay, just to monitor whether the rituximab is working or not. You enthusiastically report that this is a case of A gamma globinemia, you'll be at a problem. Okay, so always ask for a drug history. So for further confirmation, we just looked for the BTK protein, which is absent in XLA. Normally it is present. In cases of XLA, it is absent. So since the B cells are absent in this patient, we can use monocyte as an alternate population to see the BTK expression. Okay, this is normal where you find the BTK expression. This is a histogram. This is the negative control, and this is the population where it is showing expression of BTK. Whereas in patient, you find that the monocytes are not showing BTK expression. If it is present, it should come here, but here it is negative. So that's how you confirm the diagnosis of XLA, and you can send it for PID gene sequencing. Now coming to the case 4, again an 18-year-old, so it's more of a teenage old male with recurrent chest infections and diarrhea. Leukemia showed microcytic anemia and a possibility of high deficiency. Immunoglobulins are low. So again, a T cell defect or a combined immunodeficiency is very unlikely to present at this particular age group. So this should be likely a immuno deficiency or an antibody deficiency as evident by the low immunoglobulins. So we just proceeded with the subset analysis. The subset analysis showed normal T cells and normal B cells. So this didn't give any clue for us. So we further went ahead with extended lymphocyte subset analysis. And by then, since there was a refractory diarrhea, endoscopy was done, upper GI endoscopy, and duodenal biopsy was taken, which was showing these organisms, which is consistent with giardia. Okay, and when you have a close look as a pathologist, when I was doing my pediatric pathology practice, normally when we find CMV infection, when I find giardia, when I find any fungal, we get excited finding that and draft the report saying like giardia present, the fungal organisms are present, so and so. But we should take some extra time to look what's happening. Are there any plasma cells? In this case, you should look whether there are plasma cells. Okay. In this case, was showing absent plasma cells. So again, that is showing a you're going more closer to the diagnosis that there is something abnormal. So you have B cells, but you don't find plasma cells. So there is something problem in the B cell differentiation. Okay. So you find giardia and you find lymphocytes in the subset analysis, but you don't find plasma cells in the biopsy. So this is a typical case of disorder of B cell class switching, which can happen in either hyper IgM syndrome or in cases of CVID. Okay, so it can happen. So cases of hyper IgM and CVID can show disorders of class switching. Okay, so from the initial point, I was saying this: you need T cells for the activation and functioning of B cells only because of this. Because The activated T helper cells will activate the B cells, which cause the B cells to differentiate into plasma cells to secrete the immunoglobulins. So if you don't have T cells, activated T cells, or there is a defect in the T cells, the B cells will not be activated and the B cells cannot differentiate into plasma cells to secrete immunoglobulins. Okay, so this is a disorder of B cell class switching. Then we did with immunoglobulin profile where the IgM was normal, then we went for sequencing and then it was confirmed to be CVID. Okay, so this is the extended lymphocyte subset analysis what we did, and this is normal B cell class switching where you find the B cells differentiating to plasma cells or class switched B cells. Okay, so these are cells which are positive for IgM and IgD. Okay, and once they go inside the germinal center in the secondary lymphoid tissues, they lose IgD and then they go for class switching. That is, they show the other immunoglobulin molecules, which is IgG, IgE, and IgA. Okay, so this is normal class switching which is happening in the germinal centers, and this is again the same control case where you find plasma cells, which is the terminally differentiated B cells. Okay, but in this patient we found that the class switching was deficient. You find predominantly naive cells expressing IgD. Okay, we have duplex here, so don't consider this CD8. So these are all naive cells which is expressing IgD, and you find there is no class switching. So the B cells are not class switching or class switching to IgG, IgE, or IgA. And similarly, you find very, very less number of plasma cells here. So when we did the immunoglobulin profile, it was matching with that. The patient had very low IgG, IgA, and IgE, and then we sent for sequencing. It came out to be CVID. Okay. Now coming to case Y. Okay, this is a 1 year old, one month old male child. There was a significant history of sibling death. So whenever there is a sibling death, the alarm bells should ring in cases of immunodeficiency. There was a beautiful or a classic history of delayed umbilical cord fall. This is very, very classic for one entity called leukocyte adhesion defect. Okay, there were ulcers and there were fever, and this neutrophilic leukocytis is again pointing towards the diagnosis of leukocyte adhesion defect. We did blood culture sensitivity and it was positive for Pseudomonas. Now, with clinical history, it was very suspicious of LAD or leukocyte adhesion defect, and the sample was sent to us for flow cytometry analysis. Now, if you see the leukocyte adhesion defect, basically you have problems with the selectins and integrins where the neutrophils have a problem to come to the site of infection. Okay, because it has to extravasate from the blood vessels to the site of infection, and for that you need the selectins and integrins. And in cases of leukocyte adhesion defect, there will be problems in the integrin molecules, so the neutrophils cannot come to the site of infection. Okay, so we did flow cytometric analysis. So this is the neutrophil population, and we studied for the expression of CD18 and 11B, which are the integrin complex. And this is a control sample which is showing normal expression. Okay, and this is the patient what we saw, which is showing absent expression. So if it is normal, it should fall here, showing co-expression of 11B and 80 as in the control. But this patient, the neutrophils were lacking CD18 and 11B complex, and it is negative for both. So this is diagnosed case of LAD1. Okay, leukocyte adhesion defect 1. Flow cytometry can also diagnose LAD2, that is leukocyte adhesion defect 2, based on this particular marker called CD15S. Of course, this particular plot is not that of this patient. It's a different patient where this is normal control, where the neutrophils are showing 15S positivity, which is Lewis X marker, whereas the patient is showing lack of expression of CD15S. It is negative for CD15S, and this patient was diagnosed to be LAD2. These LAD2 patients typically have a Bombay blood group. Okay, so you can confirm that with that also. So that can add as a special supporting criteria for your diagnosis. Okay, so this is how flow cytometry helps in the diagnosis of leukocyte adhesion defect 1 and 2. there is something called LAD3, which flow cytometry cannot diagnose. Okay. Now, this is another case of 1-year-old child with multiple skin abscesses. We did the CT abdomen and there were also some liver abscesses. The drained pus showed Staphylococcus aureus, and this case also had, I suppose, a sibling death or a sibling diagnosed with chronic granulomatous disease. So this case, a multiple skin abscess, which is frequent infections requiring hospitalization, liver abscess. When you have abscess as the most important findings, and as well as when you have staph aureus or a fungal infections, it is very, very classic for a diagnosis of a phagocytic defect, which is chronic granulomatous disease. So basically, in chronic granulomatous disease, the problem is in production of free radicals, which is normally produced in normal phagocytes based on the conversion of NADPH to NADP, which released by a serial of molecules where a free electron is generated. The free electron interacts with oxygen, creating a superoxide. This superoxide is a free radical and very effective in killing the bacteria or the fungal organisms. This superoxide can react with water, forming hypochlorous acid, which is again a potent agent killing the bacteria and fungal organisms. In patients with CGD, this NADPH to NADP conversion leading to this electron generation is affected because of problems or mutations in one of these proteins. Okay, so as stated here, okay, so the electron is not generated, and there is no superoxide formation, and these phagocytes are ineffective in killing the bacteria, engulfed bacteria or engulfed organisms. So this is very classic. This is the pathogenesis of chronic granulomatous disease. Okay, we had a case of typical case of aspergillus infections in a case of CGD, which was diagnosed. Like when you have fungal infections in an unusual sites, then you need to think about CGD. Multiple abscess, which is recurrent, multiple infections requiring frequent hospitalization, repeated fungal infections or fungal infections in unexpected sites, you definitely need to think about CGD. Okay. Now we do a test called dihydrorhodamine test for diagnosis of CGD. There is also called one more test, which is not a flow cytometry test, which is used as a screening for diagnosis of CGD, which is nitroblue tetrazolium test. That is also being done. Basically, both the tests, nitroblue tetrazolium as well as dihydrorhodamine test by flow cytometry, is basically to check whether the free radical is formed or not, whether the superoxide is formed or not. So here the principle is neutrophils are stimulated with an in vitro potent stimulant, okay, called PMA, formol 12 bistrate acetic acid, to produce reactive oxygen species such as hydrogen peroxide. Okay, now we use a dye in flow cytometry, which is called dihydrorhodamine, and when the neutrophils are normal, because of this stimulant, they produce superoxide, which converts this dihydrorhodamine to a fluorescent rhodamine molecule, which is diagnosed, which will be picked up by the detector. Okay, so this is the principle of DHR test in the diagnosis of CGD. Basically, it is checking whether the superoxide is formed or not in vitro. Okay, which converts the dihydrorhodamine dye, inactive dihydrorhodamine dye, to an active fluorescent rhodamine 123, which is detected in flow cytometry. Okay, now this is a case where we run this is a control where we get the neutrophils because of high site scatter, and when you find this is unstimulated neutrophils, that is the neutrophils without PMA, and this is stimulated neutrophils, that are the neutrophils which are stimulated with PMA. You can find that there is the unstimulated neutrophils are not showing positivity to DHR, whereas the stimulated neutrophils are positive and showing signal for rhodamine 123, showing that the superoxide is generated. Whereas if you take this patient, we get the neutrophil, even the stimulated neutrophils are not showing evidence of rhodamine signal. Okay, so superoxide is not generated, so it is still not showing positivity or not showing signal the flow cytometer. So this is how we diagnose a case of CGD based on DHR test. If it is normal neutrophils, it should show signal for rhodamen fluorescence or in the FITC channel. Whereas this is a case of CGD, since the neutrophils are qualitatively defective in producing the superoxide, the DHR has not been converted to rhodamen, and hence there is no fluorescence, and hence there is no signal, and the population is falling with the unstimulated population. The stimulated population falls in the exact same area as the unstimulated population. Okay, so this is a case of CGD, and we went ahead and we can also check the family. So we just checked with the sibling. The sibling was showing a mosaic pattern where a part of neutrophils were normal and a part of neutrophils or 50% of neutrophils were abnormal. Okay, so this is a carrier status of CGD. And this is, I suppose, is an X-linked CGD, and this is a male child. Okay, so that is about diagnosing CGD by flow cytometry. And this is another case where a child who presented with fever, hepatosplenomegaly, he showed cytopenias in CBC, and when the biomarkers were done, the ferritins were very high. Due to the cytopenia, the physician proceeded with the bone marrow aspiration, and bone marrow was showing a lot of hemophagocytosis. Okay, so this case was suspected to be an HLH, familial HLH. So if you see the pathogenesis of HLH, the cytotoxic T cells and the natural killer cells do not kill the infected cells. Normally, in normal individuals, after a viral infection, the cytotoxic T cells and natural killer cells will go and kill the infected cells, and they will stop the infection or put a control to the infection. Whereas in HLH, what happens is the cytotoxic T cells and the NK cells do not are qualitatively abnormal because they don't have that cytotoxic granules like perforin or granzyme, or they have a problem in releasing these cytotoxic granules, perforin and granzyme, to the target cell. Okay, either there is a defect in the production of these cytotoxic granules, perforin granzyme, or there is a defect in releasing these granules inside the cell, target cell, the cell which has to be killed. Okay, so because of this problem, the cytotoxic T cells and the natural killer cells cannot able to kill the virus infected cells or the infected cells. Instead, what happens is they secrete a lot of cytokines. A lot of cytokines. That is the reason why you have elevated biomarkers in HLH. Okay. So as I said, too many activated immune cells build up, and at one point they damage our own body, such as liver, spleen, bone marrow, and brain. And that is a pathophysiology of HLH. And now, how flow cytometry will help in diagnosing these cases is by using this either the proteins, which is perforin. We can check by flow cytometry whether perforin is there in the cell or not, or we can check whether the perforin and granzyme or these cytotoxic granules are effectively released outside, which is called granule release assay. So by using these two techniques, we can diagnose HLH by flow cytometry, which I'll show you. Now, this is the case where we gated the lymphocytes, and we selected the NK cell population, which is expressing CD56, and we checked for perforin expression. In normal population, the perforin is expressed in the NK cells, and this is a patient population where you can find that the perforin is absent. If the perforin is present, then the patient NK cells should show perforin expression by the NK cells should show expression by forming a histogram peak here. Whereas since it is negative, it is not showing expression, it is falling along with the negative population. Okay, so this is how we find HLH due to lack of perforin granules. Or you can also find HLH where there is a defect in the granule release by using a molecule called CD107A. If you go back, you see this CD107A is there in the vesicles, which is containing the granules. Once the cell is activated and about to be released outside, this CD107A will fuse with the cell membrane. Okay, now we can use that particular phenotype to pick up whether the granules are released outside. If the granules are released, then the cell surface should show CD107. If they are not released, then there will be absence of CD107. So we stimulate the cells and check for this. So we get the lymphocytes, again select the NK cells and check for CD107A as we did for perforin. This is control which is showing CD107A positivity, and this is patient where you find the 107A is absent. The population, the NK cell, the patient NK cell population falls along with the negative population. Okay, if it is positive, it should have shown a peak here. Okay, and that's how we diagnose HLH by flow cytometry. I'm just moving very fast because I cannot, due to time constraint, and I cannot go in depth of it because I need to cover the topic and do justice to this topic. The other way, which has been a beautiful paper from in blood to suspect HLH and to differentiate HLH from sepsis by T cell activation profile. Okay, so in patients with elevated ferritin, TGL, low fibrinogen, and you have a differential of sepsis and HLH, when you do this T cell activation profile, you can able to differentiate them effectively by flow cytometry. So basically, this is like you select the CD8 positive cytotoxic T cells and see for expression of CD38 and HLA-DR. In sepsis, you will not find high co-expression of 38 and HLA-DR, whereas in HLH, you can find a high co-expression of 38 and HLA-DR in more than 7% of cytotoxic T cells. So when you find this particular phenotype, it is more suggestive of HLH over sepsis. So this is very beautiful. In my practical experience, we have diagnosed many cases and differentiated HLH from sepsis effectively by this. It's a very easy assay compared to the perforin and granule release assay, but it adds a lot of information. And it can help the clinician to diagnose HLH and go for further for mutations and so on. So with that, we'll just quickly finish the other indications with slides. So the other important function of flow cytometry is in diagnosing bare lymphocyte syndrome. So basically, a bare lymphocyte syndrome is where you don't find the MHC molecules on the cell surface. If it is a bare lymphocyte type 1, you don't find MHC class 1 molecules in the antigen in any of the cells, because MHC class 1 is present in all the nucleated cells of the body. Okay, so in type 1, there is absence of MHC class 1 molecules, which is HLA, A, B, and C. Whereas in bare lymphocyte syndrome type 2, there is absence of MHC class 2 molecules, which are HLA, DR, DP, and DQ. Okay, so HLA class 2 molecules is typically seen only in antigen presenting cells, whereas type 1 HLA class 1 is seen in all the nucleated cells. So by flow cytometry, we can able to diagnose this bare lymphocyte syndrome. So this is a case where this is a control where you find the antigen presenting cells are B cells, okay, the dendritic cells and so and so, the monocytes, these are all comes under the category of antigen presenting cells. Here you find the lymphocyte subset analysis, the T cells and the B cells, and you find the B cells showing HLA-DR expression, which means the B cells are showing MHC class 2 molecules. Whereas this is a patient with MHC class 2 deficiency or bare lymphocyte type 2, where the B cells are not showing HLA-DR expressions. Okay, even the T cells, normal T cells, when they get activated, as we discussed in Omen syndrome, can show HLA-DR expression when they get activated. Whereas in this patient, you find even the T cells activated, there is no activated T cells or T cells showing HLA-DR expression. Similarly, you can also diagnose MHC class 1 deficiency by studying MHC class 1 molecules like HLA-A or HLA-B or HLA-C instead of DR as we see here. Okay. And then other is autoimmune lymphoproliferative syndrome. So this is this is classically has problem with lymphocyte apoptosis, where you find lymphoid expansion causing lymphadenopathy, splenomegaly, and hepatomegaly. And these patients are very prone for autoimmune diseases, and they are causing hemolytic anemia and thrombocytopenia. Flow cytometry is very important in establishing in the diagnosis. Of course, this is one among the major criteria in diagnosing autoimmune lymphoproliferative syndrome, where CD3 positive, gamma delta positive T cell, so excuse me, CD3 positive and alpha beta positive T cells should be more in number. So the elevated T cells which are alpha beta positive should be either greater than 1.5% of total lymphocytes, or it should be greater than 2.5% of total T cell population. Okay, so this is the criteria. So if you get the CD3 positive T cells which are alpha beta positive and drop in against CD4 and CD8, you find a population which is double negative, which is negative for both CD4 and CD8. If this population is greater than 2.5%, then that is suggestive of autoimmune lymphoproliferative syndrome. Provided you have other clinical findings like raised B12 levels and so, then you can confirm the diagnosis of ALPS and you can do a mutation study like by gene sequencing. So this table shows a synopsis of utility of flow cytometry in various primary immunodeficiency disorders or inborn errors of immunity. Not going very detail about it. We have seen some of them. Apart from that, MSMD can be diagnosed by flow cytometry, like hyper IgE syndrome, the Scott-Halrich, hyper IgM syndrome. So all these conditions can be diagnosed by flow cytometry, like Tay-George syndrome, to check whether it is partial or complete, SAP70 deficiency. Many things can be diagnosed. Flow is very useful. And the other very important useful indication of flow cytometry is post-transplant monitoring. We have a case where it was a case of Scott-Halrich syndrome, and the pre-BMT, or when the patient presented, there was no expression of VASP protein, and after BMT you can find there is expression of VASP protein. So it also, flow cytometry helps in post-transplant monitoring whether the transplant has worked and are the current population which is there is a normal or not. Similarly, it also helps in prenatal diagnosis. We have seen some cases where we get the cord blood sample and we do flow cytometry assay. We have done for cases of LAD, we have done for cases of CGD, and also in a case of SCID to check whether the cells in the cord blood are functioning or not. Okay, so this is a case where the cord blood was sent. The previous child had a leukocyte adhesion defect, and the sample was sent to us. We found the cord blood sample. We processed it for flow cytometry and found the cord blood sample neutrophils showed normal expression of CD18 and 11B complex, and hence lab was ruled out. So flow also can help in prenatal diagnosis, but not in all PIDs. In selective PIDs like CGD, LAD, combined immunodeficiency, especially if you have a previous sibling death, then it is always better you do a prenatal diagnosis. The very important use of flow cytometry is verification of VUS. Now we get lot of reports where it is mentioning like this. You get a variant of uncertain significance. The clinician doesn't know what to do with this. Should I take this as a disease or should I ignore this? So when you get a genetic report or a sequencing report like this, flow becomes very handy to help you out. When you have this variant of uncertain significance, and when you have this mutation, you can phenotypically verify whether this variant of uncertain significance is really significant or not. So we have a case here where we did a exome sequencing and it was diagnosed as bare lymphocyte syndrome type 1. So we just checked with MHC class 1 molecules, as I just discussed with you. So this is a control sample, okay, and this is the test sample. I've just said monocyte patient control. This is first one is patient, second one is control, and when I overlap both of them, you can find the patient population is showing slightly lower expression of HLA-ABC compared to the control, which is this particular the green color is the patient. The other red color or the orange one is more of the control. So you find the HLA-ABC expression is relatively lower in the patient compared to the control in all the populations. In lymphocyte, monocyte, and neutrophils, it is slightly lower, and hence we can confirm, yes, this is likely to be a pathogenic variant, and we can go ahead confirming that this is a mutation is significant. So this is a very useful thing about flow cytometry, is to confirm the genotypic or results what you get in sequencing, especially as VUS, variant of uncertain significance. This is another case where we got this. So you just read the history. It's a non-consanguineous marriage. in anemia, erythroderma, exfoliation of skin with seborrhea. So it more goes towards an woman syndrome like phenotype. You have reduced B cells, hypogammaglobulinemia, absent class switching. So, and we did flow here first, and then it was sent to sequencing. So we suspected a primary immunodeficiency with a B cell class switching defect, query Omen syndrome or anything, and we found the sequencing result coming to be chronic granulomatous disease, and was said uncertain significance. We did DHR, and DHR was perfectly normal. So this mutation cannot be entertained, and this is should be an uncertain significance of which is not likely of any pathogenicity. We need to ignore that. So this is another example where we need to correlate between the genotype and phenotype, and flow is very handy in that. So coming to the last slide, after a very lengthy lecture, the take-home messages is keep a very low threshold for suspecting PIDs, because PIDs are generally underdiagnosed. So you keep a very low of threshold and always screen the patient for PID. When you have a very repeated infection in unusual site, unusual organisms causing infections, just check for PIDs. Flow cytometry, as I told, is an efficient tool for rapid diagnosis and studying the diverse immune cells. It's a very, very rapid thing, because if you do a sequencing, the results may take, depending upon the lab, from 2 weeks to 1 month. Whereas flow, you get the same day report. Useful in post-treatment monitoring after a transplant or in prenatal diagnosis in some cases, but not in all PIDs. Nevertheless, genetic studies has to be done for confirmation and counseling of the patient. Though you do a flow cytometry and establish the diagnosis, you need to do a genetic study to confirm it and for counseling. And as said, final diagnosis has to be made after the phenotype, that is clinical and flow, with the genotype, which is from the sequencing results, after correlating both of them. The basic idea is you do an early diagnosis, you do an hematopoietic stem cell transplant, you can save the life of the child who is suffering from inborn errors of immunity. So that is the basic idea behind this. So with that, I just conclude, and I thank you for giving the opportunity. And if since it's being a virtual one and caught up with another meeting, I'm just giving a recorded talk. If you have any doubts, you can mail me, and I'm available with this mail ID, and I would love to answer your questions. Thanks a lot, and wish you good luck. Thank you.